Welcome, everyone. This is Rob Waters, Program Director with State HIT Connect. I'm excited to kick off today's Industry Insights webinar, the title for which is Reimagining Identity Across the Broader Medicaid Enterprise with Unwinding as the catalyst. I spent some time with this particular presenter group in preparation for today's session, and my understanding this is really going to be an exploratory conversation, and the group also want to try and interact with the audience as much as they can in terms of the Q&A portion. But to do that and create as much value as possible, please do connect with the chat window and enter your questions around some of the approaches that will be explored as part of today's session. So certainly that there are a number of themes that are going to be touched upon that is very much in fitting with a lot of the discussions we've had this year around technology reuse and integrated service delivery, person-centered care, also program integrity, and of course the elephant in the room, PHE unwinding. So this should be a really vibrant conversation, but both exploring the potential of identity in terms of different MES functions, but also how that can be implemented across the Medicaid enterprise and not just on a module by module basis. So we're really looking forward to today's conversation. Without further ado, I'm going to pass you over to Trey Harrison with the Lexisnexis team, who's going to be quarterbacking the presentation, and he's going to further introduce some of the topic and of course his co-presenters for today's session. You'll hear from me again towards the end, and I'll be helping out with the Q&A. Welcome, Trey.
Thanks, Rob. I appreciate it. Very excited to present here today. This topic is near and dear to my heart. I'm going to go around the horn here in a second, introduce the other presenters, but by way of introduction for me, as he said, my name's Trey Harrison. First started working in Medicaid for a company called Consultech a while ago in the 90s, and worked largely in the pharmacy benefits management space at that time. Did a tour of duty at Optum, where I worked a lot with data warehousing and program integrity, and sort of established this career arc of helping states use data to either improve outcomes and make people healthier or catch bad guys trying to do bad things. And it wasn't until I came over to Lexisnexis about 13 years ago that I realized just how little a slice of the understanding that Medicaid agencies actually held in their own data, and that there was this entire other side of the coin that the agencies didn't have really any insight into when it came to both members as well as providers. And so it's been an exciting 13 years for me here at Lexisnexis to apply identity insight and say, oh, wait, while you're doing that in the Medicaid enterprise, or while you're implementing this module, wouldn't you benefit from some identity insight? And in the course of doing that and working with Doug Tomlin, my colleague here at LexisNexis, we've discovered some trends that we'd like to talk about here today in terms of what do states understand about people, how is that understanding being handled today, and should it be sort of centralized? Should states be thinking about identity as a standalone topic of its own and applying it to the modules, applying it to endeavors in a consistent fashion? So that's what we're going to talk about. We're going to talk about how identity data for members and providers is used today in the Medicaid enterprise, and sort of paint a picture of a more centralized approach, a singular approach to it. Very excited to introduce our presenters. I'm going to go around the horn in a second, let Doug introduce himself to start off. We also have Chris Valama from mostly Medicaid, as well as John Anderson, who's done a lot of work with Georgia to give that impression from the field, sort of the real world applications of how identity is being used now and some challenges in the current model. So with that in mind, Doug, why don't I send it around to you, and you can hand it off to Chris and John for them to introduce themselves.
Yeah, no, Trey, thanks a lot. Just real quickly, again, like Trey mentioned, he and I have run some similar paths. I too started with Consultech back in the 90s and actually stayed with that company and its several iterations for about 15 years, running different MMIS accounts around the country, and have been with LexisNexis for the last 9 years in a business development role. And certainly this identity subject, again, similar to Trey, when I came here, really it began to resonate with me that there was so much more, so much better we could do with the identity in within the world of both an MMIS modular enterprise system, but also even across the entirety of a health and human services, social services agency setup. So really excited about the topic to talk to you guys today. So with that, John.
I'm John Anderson, and I just recently retired from the state of Georgia after a little over 30 years of service. I started as a food stamp case manager and worked my way up through different aspects of the system. I think I've done just about everything that there is to do in eligibility, and enjoyed every minute of it. I'd like to continue to do this type of work as we continue to move forward. And so this topic is very exciting to me. I think it's certainly very timely. So I'll go back to you.
And Chris.
Chris Villama, I'm a partner and chief growth officer at Mostly Medicaid, also a former state government person for about 15 years in Alabama state government, finished as the chief information officer for the Alabama Department of Mental Health, but have worked for the last 8, almost 9 years in consulting with various states, service providers, entities that provide solutions, including Lexisnexis, and proud to be here today.
Very good. All right, why don't we just kick things off? We're going to talk about, as I mentioned, we're going to talk about identity having a broad impact across modules. We want to start off with some insight that John brings to the table in terms of how the identity data typically comes into a state Medicaid agency, the notions of how it's captured and how the systems interact to get this baseline understanding of a member in the Medicaid enterprise. As he said, he's been doing this for a long time, and we're going to let him kind of walk through the typical model of how this data journey gets started.
All right, thank you, Trey. The building materials of identity all start with an application for benefits, and in the eligibility world, all these things are consumer driven. So customers are reaching out to the Medicaid agencies to request services benefits, and they can do that through paper application, to a fax application, to customer portals, to telephonic applications, and ex partes. That sometimes we get referrals from other systems like healthcare.gov as well, or state-based exchanges, and those states that are doing that type of work. So a lot of that work all comes, no matter where the source comes in from, you have to identify the individual first. The states have to work on doing that. Some states have some very robust algorithms that help match up individuals before they get escorted into the system. And some states rely still on a human-based interaction. With eligibility, there's always what I call a race to registration, because you can't start an application until you've done that identification of the individual. And once you've identified the individual, then you can start linking them to other family members after their identity has been established as well, to establish a case. So applications can't get started, or benefit requests can't get started until that identity piece has happened. So there's a race to get that done, because if delays happen at registration, then there's a delay in getting the case done, and that's not a good thing for anybody involved either. In the olden days, when customers used to come in, they could, the registration clerk could ask clarifying questions to them to say, can I see your ID, or do we have your name spelled right? Those types of things that can happen. But in the electronic world, it's a little bit more difficult to do that. So the registration clerks are doing the best they can with the data that they have to try to register those cases as quickly as they can. On the right-hand side of the screen, with the Medicaid Managed Information System and reuse of data, you'll see after all the cases are completed and they're approved, they'll come in through that top area where eligibility systems come through. Some states like Georgia have other systems that feed in there too. They also may have some direct inputs into the MMIS systems. Like public health may be doing presumptive Medicaid applications for pregnant women. You may have hospitals or federally qualified health centers that are doing presumptive eligibility that came out of the Affordable Care Act. And again, you're going to have a lot of this information that's coming and going in and out of the MMIS system, including the managed care organizations that may be keeping up with individuals a little bit more often than they keep up with in eligibility. The difference in MMIS, they're looking for fast payments. These hospitals and public health departments are wanting to get a Medicaid ID number so they can bill for services as quickly as they can on that one. I think they do the best they can to try to match up individuals that may already be known in the MMIS system. But if they don't take the time to make sure that they're checking and cross-checking all those things, it can lead to duplicate IDs by the time the presumptive eligibility is followed up upon by the eligibility staff. And some of the causes of duplicate IDs, really have to do with a lack of time spent researching all possible IDs. So you may have to go and look at name, address, social security number, date of birth. You may have to match different things and different versions of names to try to get the right name. Newborns, I think, are problematic. Sometimes you'll see that when they come in from the MMIS system, a lot of times there's not a name on there other than baby girl, baby boy. And when that comes back over to eligibility, they've got to try to link that up with the right mom and then be able to correct all that information and tie it all together so that there's one identity for each of those individuals in the newborn area. With pregnant women, you can see that sometimes, especially with some of the names that come from other cultures. They may, in the health department, they may have the last name first, the first name last, or they're misspelled, or sometimes the names are reversed. So that has to get corrected again, when the final eligibility is done as well. And as I said before, there's other data systems are bringing in addresses and other updates back and forth to the MMIS system. And sometimes you don't have that information flow back over to the eligibility system in an automated fashion. So Trey, that's really sort of the foundation of identity on the eligibility side.
Yeah, great. Thanks, John. So John points out some immediate sort of concerns about the very first establishment of the identity in terms of conflicting priorities, conflicting roles, interconnected systems, disconnected systems, the kinds of things that can really, on their face, by themselves, be problematic when it comes to eligibility decisions, as well as just quality data to understand the individuals. This gets compounded when you talk about it in the context of all of the other modules. This might not be all of the modules. We really had to think hard about where all this could apply. It was easier to come up with where doesn't identity apply. The actual payment of the claim is probably the only place we can think of where we really just don't have much to say. If the rules are set up right, the claim can pay. But when you talk about all of the points around on this compass and all of the modules or initiatives that states can undertake in the benefit of the Medicaid enterprise, they all have their own needs as it relates to identity data. It's not just coming through the keyhole or coming through that front door, as John describes, with its own problems. When you go around and look at each of these components of Medicaid, they have specific needs on how to understand that person, how to understand that Medicaid member, how to understand that Medicaid provider that either might not be captured in the eligibility process or might not be readily translatable within the actual module where it applies. We're going to go around the horn and look at these kind of one by one and talk about how identity impacts that aspect of Medicaid. That's what we're going to jump into now. Doug, anything you want to add before I throw it over to you for the beneficiary enrollment stuff?
Yeah, no, I think it's important, as we've, I think, all really become very aware of. I mean, I've been in this world for the last, 25 plus years. I know all the gentlemen here have been in for that long or longer. And certainly the people that are on this webinar and watching this webinar, watching the recording, have been in this market, in this arena for many, many years. And we come in to serve individuals. We come in to serve people. And that's why I believe, both Trey and I, and certainly John and Chris are passionate about this idea of making sure that we're keeping consistency with that individual, keeping consistency with that person so that they are dealt with in the most efficient and most helpful way possible. I think a lot of times what happens is that identity becomes muddled and watered down once it gets through the eligibility and over either it be time or the way the technology is set up, that the identities are bifurcated and you lose that person, you lose who that person is. And I think that results in, unfortunately, not the most robust, most consistent amount of services and positive outcomes that you could look for. I think another point to make is, John showed all of those inputs of where information's coming in from, be it FCQHCs, from the MCOs, from health departments, from all the different agencies. And that's great information. And it's information that we want to maintain and utilize, but we still want to manage it through a single lens and not have it looked through multiple lenses, so that you begin to, again, lose the focus on who that individual is, because all that data can help you, but it can also hurt you in regards to maintaining that consistency on that identity.
Very good. All right. And so the next part of this presentation or conversation, we're going to be walking through these modules or initiatives sort of one by one, and sort of putting a finer point on what else is needed, what else could be provided, or where is this module needing to reach out for ancillary information about the identities to make sense of, for it to operate. So when it comes to enrollment, we've talked about it a little bit. You have to validate that the person is representing a legitimate identity, that they're representing their own identity. States need access to things like asset verification. Is the person living in state? Is the person alive? These sort of essential elements in terms of making the eligibility decision. And then ultimately, especially as states look beyond simple healthcare, they're finding they need insight into the socioeconomic factors that might be impacting health. Maybe there are some cross-program initiatives that we'll talk about in a minute that need to address something like homelessness or lack of access to transportation or things like that. These are the kinds of insights that are needed when it comes to member management, as well as just the basic blocking and tackling. How do I get a hold of this person? How do I contact this person? Where are they living now? And we'll talk about how that plays out. Chris, if you've got some maybe insight from the field in terms of how this is handled today or challenges.
Right. And I think this is a good place for us to touch the elephant in the room that Rob mentioned around the unwinding. All of this elevated, under COVID. And as you see eligibility factors shifting in flight and people having to make decisions about eligibility that's different, tomorrow than it was today, the factors that they need to know and when that timing is going to happen is a huge concern. And so we're seeing that play out in the unwinding scenario and in each of these areas, the eligibility changing, the timing of when that's going to happen, the current and accurate contact information not being clear about, do we have the right contact information today versus, people that we haven't touched in 2 years because we didn't need to during that period. And then the same thing with essentials and thinking about whole person care. How are these individuals going to transition out of the public health emergency and the unwinding and changes in coverage? So all of these factors are in play in that scenario. It's not the only scenario, but it's one that highlights the need for this sort of management even more.
I'm glad you mentioned that. We've been downplaying the true unwinding aspect of this from our standpoint. We've been doing this sort of thing. We've been augmenting the data along these lines for years and years. Unwinding, we're just sort of viewing as the ultimate case in point for this doesn't end. And the moment of enrollment, the moment of eligibility is not the last time you ever need to know about the person. As we all know, these folks move around all the time. Their contact information, their family situation, all of these things change all the time. So identity data is not a moment in time. It's a continual process because, as folks' needs change, as their locations change, Medicaid needs to be responsive to those kinds of changes. Doug, anything else before we go on?
Yeah, I think we've covered it well. Again, that this is sort of the beginning building block, but obviously we've got several more that we want to talk to. And again, essentially the idea of, as the person moves through each of these modules, it's so critical that we maintain the consistency and maintain the integrity of who that person is, and having that centralized approach to maintaining that identity begins here and then just moves on. As Trey said, this is just the first stop.
And then worth noting that members aren't the only stakeholders with identity issues in the Medicaid enterprise. Providers are there too. This is very much home base for us here at Lexisnexis. We're up to almost half of the states in the nation using our data to do that upfront screening of providers. Are they safe to deal with? Are there license issues? Are there any revocations or sanctions that we need to know about? We do that day in, day out across basically all the integrators who work in provider module work. But it's also, it's important to keep tabs on whether these people are safe to deal with or not. But when it comes to directories and when it comes to sending members to providers or matching them up with provider networks in the case of enrollment broker, we find that quite often states, as well as payers, do not have good, accurate information on where the offices are. Are they open? What languages are spoken? All of these really important things when it comes to choosing a medical provider are hard to keep tabs on using state-only resource, and that's also an area where we've been augmenting. Chris, I believe that's some stuff you've seen in the field.
It is, and we've seen issues both from the perspective of a single source of truth of what is the active provider network that we have today, and also just challenges and issues with people who applied to be Medicaid providers are not necessarily going to remain Medicaid providers, and that end date of when do they stop being a Medicaid provider is often a lost element of the work that needs to happen with directories and keeping them in sync, as well as having multiple different databases that are keeping up with different information for different programs. So sometimes the licensure database is separate from the actual Medicaid enrollment database. And how do you sync all of that information together? Who determines who's able to be a Medicaid provider is sometimes in a separate system, separate database, separate agency from Medicaid. And so there's that syncing up of the different data sources and making sure that the licensure boards and those who are responsible for determining who an eligible provider is for particular services are in sync with the Medicaid data that is in their database about how people are getting paid. And to your point about locations and where services are being provided, those same kinds of issues are also in those syncing of databases, that there are different types of information that are collected by different entities, and sometimes they have different information based on when that data was collected, and who's got the most accurate information, what's most up to date is often a huge challenge.
Handling, that's very much the theme of everything we're talking about here, doing things piecemeal and syncing different systems and trying to connect individuals across various data sets is very much what we're painting as the sort of current state solution. We're doing the best we can. Hey, we got to stand up a provider module because providers got to enroll and all that stuff. That is a very different discipline than maintaining a single understanding, single source of truth on that provider's identity. It's just a separate discipline. Standing up a portal for a provider to enroll through and managing all the rules on the back end for checking the various things is different than the kind of identity resource work that we're talking about here. All right. Provider. So we're going to click through a few more of these. There's a few obvious ones. If you're wanting to do fraud, waste, and abuse work, and there are people out trying to get you, they are going to try to hide things from you, important things about their identity. For any level of provider risk factor, we already talked about screening in terms of sanctions and license revocations and things like that. We need insight into. We also need insight for program integrity work when it comes to looking into ownership, when it comes into looking at hidden connections or things that aren't disclosed on provider applications, and looking at members and providers together, and is there any inappropriate activity there? These are all the kinds of things where we have done work in a piecemeal fashion, but we've had to bring in and augment strictly for fraud, waste, and abuse because the Medicaid agencies don't have that deep insight on their own. So in a program integrity engagement, we bring that to the table.
Yeah, Trey, that's a great point. I think this is great that it's in the order it is, because it really takes the first two building blocks, first two modules, and really restates how important having that, again, I'm going to repeat myself over and over again, and I apologize, that consistency and who that identity is, who that person is, so that when you are dealing with these fraud, waste, and abuse type situations, that you're not losing anything. You're not looking at these individuals differently. You have a strong, ever present, ever updated, ever evolving look at who both the individual is and who the provider is, so that when you're interjecting that data into these review processes, these program integrity processes, that you've got a consistent view across the spectrum. You're not eliminating or you're not losing any of the effectiveness that you should have based upon going in and pulling in a separate data source or lack thereof of a separate data source to do the work.
Well, you're not just pulling it in, you're paying for it piecemeal too, right, Doug? Because, you know, if you didn't collect it over in this one area and you need it for fraud and waste, you can look at program integrity RFPs over the last 5 years. They're asking for ancillary data. They're asking for deeper data on providers or deeper insight into members. And sure, you can pay for that within fraud, waste, and abuse, and you can pay for it all on all these other modules that we're talking about. Or well, maybe we should take a step back and say, what does the entire organization need when it comes to providers and members? And certainly economies of scale would play out there in terms of paying piecemeal. You could get a centralized understanding.
Excellent. Yeah, nothing's free.
Third-party liability, we're gonna start getting into those and kind of going through them a little bit more quickly. I think folks are probably starting to get the idea. Third-party liability, not necessarily the first thing you think of when it comes to identity, but states need to understand when someone passes. State needs to understand whether there are assets that can be recovered in a subrogation process or something like that. And they need a solid way to connect an individual on their roles to the resources that are available commercially to let you know what the commercial insurance impact is on that person potentially. Okay. And again, these four over here can interrupt me anytime they want. If folks online have questions, please drop them into the chat, and Rob's going to hit us with it when we wrap up. Care management is a very important one. Not only are you talking about needing to link an individual successfully, so you know that Trey Harrison is the same person on Medicaid as Wilbur Harrison over in SNAP, and maybe WM Harrison in a housing program at the state or something along those lines. You need to be able to sync them up, but you also need to understand what it is about Trey that needs addressing from a socioeconomic health risk standpoint. We've done work with Medicaid agencies looking at things like homelessness, looking at patterns of known homeless versus their general populations to see, are there patterns over here so that where we can intervene before someone becomes truly homeless, things along those lines. And again, basic blocking and tackling. If you don't know how to reach someone or you don't know where they are really sleeping at night, good luck trying to manage them. You can have the best care coordination program in the world, banks and banks of nurses ready to call people and do some outreach and get them to stop smoking and all that. But if you don't know where they are and you can't reach them, it's no good. It's no good. So this is one of the ultimate cases in point, honestly, to needing deeper insight, especially as Medicaid agencies look outside their traditional walls to address more sort of non-medical impacts on health.
Yeah, and I think this is a perfect example of one, Trey, where it is so critical that you have not only the consistency, but the breadth of data that's going to be important to informing you on what's going on with these individuals, with these people. Where are they, having challenges? Where are they hurting? That is impacting their ability to successfully manage their care and do the types of things that are going to allow their, overall life to be impacted in a positive way by the program, be it Medicaid or others.
And we've talked to some states who have done a good job when it comes to, at the enrollment moment, getting surveys, right? Getting kind of a questionnaire format, where kind of a baseline of socioeconomic health risk factors. And that's well and good, but very similar to the contact data issue, keeping that fresh and understanding how people's scenarios change over time, you just really can't accomplish with a survey methodology. Just by way of example, we see foreclosures, we see evictions pretty much as they happen from authority sources. So that is the kind of high impact information that you'd miss because a state agency doesn't have the expertise in data aggregation and the connections we do to the original sources and things along those lines. So I don't think that we'll ever replace questionnaires, but certainly having quicker alert, quicker monitoring, understanding of people's changes in scenario are very, very germane to care management. Data warehouse, important module. My old stomping grounds at Optum. You know, analytics are only as good as the assumptions that they're based on. You can do a lot with distance traveled to a pharmacy to see suspicious fills, but if you didn't know that Trey just moved somewhere else, it looks like he went 100 miles to get to the pharmacy. Great analytic, it's wrong. Because it doesn't have that baseline of accurate information. And this is an area where states could augment with additional information to look at, additional for analytic purposes. Maybe you can't proactively change that person's address, but you can do some analytics on where he is living. And again, there's always a master person index theme across all of this. It's not a core competency of a Medicaid agency. I would argue it's not a core competency of the integrators when it comes to having context on individuals versus just using algorithms to sort out sort of known name variations and things like that. It's a competency over and above what's being done within the module itself.
And I think this module data, you know, we think of, data warehouse as maybe in some respects, it's sort of the end of the road where you're bringing everything together, and it's sort of the culmination and the review of all of the information that you have, which is fine. And you can certainly go through and do work to refine that data and make it as clean as possible and do the things necessary to, deal with the bifurcated way that we've gone about dealing with all of the different modules from an individual or from an identity perspective up to this point. But our take here is, wouldn't it be better to start with good, consistent data from the beginning, have that permeate all the modules from the beginning, and then when it comes to a data warehouse, it's already in a clean manner. It creates less risk for you in regards to the effort that you have to put in to just get it right. And secondly, then utilize it in the myriad of different ways, from reporting to, obviously providing services and the other things that are so beholden to this data warehouse data. So let's start at the beginning and get it right, rather than, focusing on trying to deal with it at the end.
Well, and something I would call out here too, harkening back to the provider side, is, the reliance on the NPI and the way that was implemented versus the way it was intended, and how, we now have many providers who have lots and lots of different NPIs for various reasons. There were systems that couldn't accommodate certain things, and so people were told to get multiple NPIs. And so the whole idea of having a single identifier went completely sideways. And now, if you use that as your single source of truth to try and say we can report everything based on NPIs, you're not capturing, that full identity of a provider. That there's work to do to tie other pieces together and tie multiple NPIs together and say, well, really, these three are the same person or the same entity, or however you want to look at it. There's that magic that people are going to rely on NPI as the single identifier. And if you do that, you're missing, a huge piece of the picture.
Oh, very good. Yeah, Jug, I hadn't thought about data warehouse being the lint trap of the organization when it comes to data, but it kind of is. We'll fix it there. It's needed in the operational data stores too. Enrollment broker, really similar message here. As you're matching folks to plans, as you're matching folks up to the best sort of provider network and plan for an individual Medicaid member, you need to know where the Medicaid member is, and you need to know accurately where all the providers are, right? First of all, and then you need to go from there in terms of that baseline understanding of the folks that are being ultimately paired up for the assignment to be successful. From a pharmacy standpoint, even PBM, even the pharmacy aspects of the Medicaid enterprise have needs. While we do the screening on a monthly basis and monitoring on a monthly basis, the pharmacy operations, as many of you know, require a validation of the provider's license to prescribe on the day that the prescription was written, and that's a moment of fill check that needs to be done. So
And
a
Trey,
good example of I need more over here. Like one module saying I need more identity over here. But yeah, go ahead, John.
yeah, and too on the member side, sometimes if identity is not done correctly through member eligibility, they can cause issues with utilization at the pharmacy because the pharmacy's asking, what's the date of birth, what's your name and all that. So if it's not correct, then sometimes I've heard pharmacies refusing to give the full prescription,
Sure.
until that's resolved, and it has to go back through eligibility, get it corrected, then feed back over into the system.
Confusion on that front is powerful. It's meaningful, right? Somebody standing in a pharmacy needing the meds. That's a powerful moment. That's a real time moment,
Right.
with real time consequences. It's an excellent point. All right. Anything involving cross program work? Anything regarding using working with sister agencies? Really forces a state's hand when it comes time to understanding a single view of an identity as it appears in multiple data sets. This is not an uncommon problem. This isn't a problem that hasn't been talked about for decades and decades before, but as states work to collaborate more closely with their social service peers and sister agencies, that need is heightened. Not only to be able to connect someone across multiple state data sets, but also to give those sister agencies an indication of what are the challenges confronting Trey as a Medicaid member, what needs to be done to make him more able to take care of himself or more healthy in his social and economic environment, things along those lines, to not only just make that linkage across to another program, but give that other program some very, very targeted insight into what needs to be done in Trey's life to help him out. Yep. All right. So we've been kind of talking about that as the current state, right? We went around the horn, and each of these modules or each of these initiatives have identity needs, and the current state is for the states to play whack-a-mole. Okay, I'm putting in a provider enrollment module. I need to get some more identity data for that. I'm putting in a new IES. I need to inject some identity data for the verification or AVS or whatever it is. Go all the way around those things we talked about. Playing whack-a-mole, you are paying more and creating an even more disconnected system than the one we started with before we started augmenting data for all of these module by module needs. It's not the most efficient way to run the process. This is the environment in which Lexisnexis operates today for identity insight. We work with pretty much all the integrators and module vendors in the marketplace. We can keep chasing them down these rabbit holes, and we can keep being the mole that pops up in an environment. But I would be remiss if I didn't point out that while we can bring benefits, screening's great and provider enrollment, things work. It has really been gnawing at me for these past several years, and Doug's probably going to start smiling, that it's not the right way to do things. That handling identity piecemeal costs more and creates problems. That's pretty much the very, very briefest statement of my thesis here. So I know John has some things to say on this slide. Doug, anything you'd add before we throw it over to John?
Yeah, I mean, again, I think the points on this slide, speak volumes, and your quick assessment is extremely valid. Just being able to ensure that there is, again, I'm going to use that word, consistency in the individual, and I go back to my earlier statement where, we've got to remember that these are people, they're very unique, and having a confused view of who those individuals are only hurts them, and it hurts us in regards to us trying to meet the mission that we're all here to do, which is to serve those individuals and to protect them in regards to getting the services that they need and getting the assistance that they need. So having that great view, that view that is going to be one that you can trust is so important. And again, I appreciate the fact that we've done great work up to now, but I do think that there is a better way to go about it.
So John, there's some real world costs and real world problems that come from handling this identity topic piecemeal, are there not?
Yeah, absolutely. I mean, it causes a lot of problems. People don't really think about how problematic they are. But just to give you a little insight into what states have, whenever you have like a duplicate ID or an incorrect ID that gets set up, it's got to be resolved at some point. So either you've got to merge that ID in with a correct one, or most unfortunately, you have to unmerge it when it gets merged incorrectly. And those things are really time consuming, and they're problematic when you don't do them correctly. But they're all a result of bad identity management up front, and that's why it's so important to do that. And my days with Georgia, we had one expert inside the Medicaid agency and one expert inside the eligibility agency that handled these unmerges and requests, and so that the resources are really tight in those areas. And having conversations with with both of those individuals, it can take half a day to a day to unmerge somebody that was merged incorrectly, because you've got to sort out every single one of those claims, every single one of those benefit months by month, to make sure that it gets put back in the right place. Because automated systems, you can't just hit the reset button and put it back the way it was. You have to go back and pick that out individually. So there's other issues around that and eligibility that prevents some efficiencies, like Chris was talking about earlier with PHE Unwind, and trying to make sure that we've got the right contact information and the right individual. That can also prevent automated processes from happening inside the eligibility system when people go to renew. If we've got the right addresses and the right benefits, and the customers are well known to us, and sometimes that can lead to a no touch or a low touch application that the system can handle, and not have to actually pass that on over to a case manager, because you're able to effectively match up all those federal and state and sometimes private databases that contain the information that's needed to make a determination on somebody's continued eligibility. They can also have an impact on benefit issuance. If you have two people, that one person that gets two different IDs, sometimes they can get duplicate benefits, and that's not allowable, in any program. And so that sometimes has to be cleaned up. It can be fraud. It could be, inadvertent program violation, but one way or the other, guess who gets to pay back those benefits? The customer. So that's never a good thing for, our safety net customers to have to repay something that they didn't know they were going to have to repay. So a solid identity program, identification in the beginning is very important. Claims is another one. Whenever you have claims that come up, that follows a person. So if you have somebody that, a claim was incorrectly assigned to an individual an identity, when that claim is going to follow that person around for the rest of their life, to be until it's resolved, or it gets, resolved in one of the merge unmerge processes, sometimes that we talked about before. The fraud penalties, like you were saying, I think Trey and Doug earlier, on the provider side, that sometimes you've got providers that have claims and things that are preventing them from being a provider in Georgia that happen somewhere else. But you have to know, what those things are. We've got the same thing in eligibility. People can't receive SNAP benefits and TANF benefits or Medicaid benefits in the same month in two different states. So those are things that have to be resolved, pretty quickly, to make sure that we look at that. And then in some of the programs like SNAP and TANF, there's lifetime limits for, intentional program violations. So if somebody has 3 or more, IPVs, as we call them, intentional program violations, they're not eligible to participate in the program, even if they move to another state, because that's how the programs work nationally. And then again, I alluded a little bit to, some of the issues around age, getting the right date of birth in there. When somebody went to try to present at the pharmacy and we didn't have the right date of birth in the system, because of a bad identity, establishment in the beginning, that causes them to have problems with accessing benefits. But it can also have other negative impacts, like the age limits for Medicaid and CHIP program. If you've got the wrong year of birth in there, somebody could get, benefits a year too long, or they could, lose benefits too early if we don't have the right date of birth in there for identity management. same things that whenever things go over into the MMIS system, if some of those things aren't correct, it can cause issues with managed care payments. You could get duplicate managed care payments out there, which are not good, for any state. It can get them in the wrong benefit packages. It can lead to incorrect utilization issues, like we were saying before, if you don't have the right individual there. And again, all the claims are tied to those individuals, so that when that person grows up and ages out of the program, they may go over to establish their own case, and you want to be able to keep that history of those benefits, those claims tied to that individual, so you don't have a break in that type of service provision. So client identification, again, let's summarize it real quick on my side, is the most important step, which is the cornerstone of all the eligibility functions. You've got to get that right. And when states have workforce challenges and workforce demands like they have right now, they have less time to deal with those issues, and getting it right in the beginning will prevent a lot of rework. And then getting it right also will allow states to access more automated systems, automated processes, to be able to be more efficient in their work and serve more customers. So that's what I have on
Thanks,
that.
yeah, thanks, John. Chris, anything to add in terms of the challenges of the current state, or you think we hit the topic? You're on mute briefly.
Overall, the current state is, we continue to deal with this back and forth on the different aspects of how these systems interact and how the modules interact. So I think that's the only point I would throw out in addition, is that the interaction points are a real challenge in general, and in specific instances where they're required to have the same information. There's challenges in those interactions between the modules.
Excellent. Well, I appreciate you guys both giving the sort of the industry-wide perspective and some real world stuff there, John. That very much tracks with what we have seen. As I mentioned, we've chased all of the individual sort of points around the circle that we talked about. We have augmented in many cases just through a prime contractor or through a module vendor or through an integrator. We have augmented piecemeal these identity needs, and we have successes all the way around all these points of the circle. But again, taking a step back and thinking about how it could be as a single shared resource across the Medicaid enterprise. I've already mentioned, obviously we bring in economies of scale in terms of not purchasing identity data in all these little disconnected spots, but just getting one sort of economy of scale look into members and providers. But it also can flip around the disadvantages that we've talked about on this module by module approach in terms of validating and cleansing and getting the right information for the eligibility moment, all the way to collaborating with a sister agency on how to best keep Trey from becoming homeless, from uncovering collusive data indications between providers to making sure somebody signed up for the right Medicaid managed care plan for them and their provider needs and where they really live and things along those lines. It is possible. By doing all of these things piecemeal, one thing that we have learned is that the implementations can be thin. We don't stand up a provider enrollment module. We don't stand up an IES. Heavens to Betsy, we don't want to stand up an IES. You guys can keep that business, the people who do that. But we inject in very standardized, secure ways, either via API calls or batch transactions. We can interject, and we can do it in a common way across all of the modules. With that, I want to be cognizant of time. Let me give any comments to the other presenters before we turn it over to Rob to go through some of the questions.
Just last comment, and again, I appreciate everybody's time. All of the technology that is associated with the modules, is outstanding, and we've been, like Trey said, a part of many of those modules and have contributed to that technology in regards to the data that we've been able to provide to help sort of fuel it. Our premise here is, again, not that the best practice that is a accounted for in the intention of the module program and the module process. We think that is still something that is a very worthwhile approach. We just feel like at some level the identity needs to be looked at the beginning. Again, it's all starts with the person and making sure that we focus in on that person in that identity to feed that technology in a consistent manner is the premise that we feel will allow everything to work more effectively to serve the individuals that it's intended to.
Well said. All right, Rob, you want to see what we've got in the way of questions, and I'll throw it around the horn as we'll try to answer.
Absolutely. Thank you. That was pretty robust interchange amongst the group, and I think hopefully the audience have got a good handle on some of the key application functions and some of the implementation type scenarios. And would you getting in terms of questions, just some initial items here, just related to how states can engage in this sort of approach. One or an initial question might be to you, Trey, and the group, which is this or would you characterize this as an idea as a service solution approach that Lexisnexis is introducing here?
Yes, all of our products as such as they are delivered as a service. I've been just a little pet terminology for me. I like to think of this as the identity module. I think it should be a module of its own. I think some people laugh at me. Some people think that's a great idea. But the level of a service level offering to standardize identities and to interject identity data where needed across all of the modules. A very thin layer in terms of implementation, easily interacting with the modules as they need, keeping one single record clear across all of the systems in the enterprise. It's all doable. Like I said, we've done it along all the points of the compass, but tying it together and giving the state the comfort and the assurance of having the right data at the right time, no matter what the module, no matter how somebody's name is spelled in a different system versus the other one, is exactly the concept we're talking about.
Awesome. Okay. Another sort of implementation or engagement type question came up here. What does implementation look like? How much work does the state have to do with the data itself? I'm assuming from my impressions that's fairly minimal, but over to you, Trey.
Well, I'm going to throw that one to Doug because he's done the most actual work on MMIS systems, more than me, certainly. You want to talk about the integration layer, Doug?
Yeah, like Trey said, I mean, it in and of itself, it could be a module on its own. Again, a very thin layer module, nothing that would require a significant period of time to stand up. And in the way that you approach it, you could go a couple of different ways. We can maintain that data within ourselves, within our systems, or it could be built in concert with, say, an MPI type solution, which we can offer as well. So it can fuel. It could be its own module where it's standing there, constantly updating all of the different modules and tying into it. The architecture of that would be something that could be reviewed and talked about and done in a variety of different ways. Or it could be in the confines of a master patient index, where again everything comes and goes out of that MPI. But at the root of it, and there's lots of MPIs out there. At the root of it, though, it all goes back to the data and having that singular focused data source for the purposes of fueling that information. So again, the way you would implement it, I think there's a variety of different ways, but at the crux of it, it's maintaining the consistency of the data that is that fuel.
And I think it's worth mentioning, Doug, I'm glad you mentioned when you talk about implementing Medicaid module, might want to just curl up into the fetal position and think about, 2 years, 3 years, system mods, things like that. We're not talking about building something. We have the identity resource. We already obtain data from tens of thousands of sources on a moment-to-moment basis. That data is sitting there. It's the application of the data within the modules that just needs to be tweaked. Send us the inputs on the provider, and we can tell you right away, are there any sanctions? Are there any things like that? We need very little from the state to deliver our benefits. Basically, just an input of an identity, and we can keep that standard. It's a very different thing, and it was a sea change for me coming from Consultech and Optum to here when it came the difference between implementations. It's not capital I implementations and get a whole bunch of people in the state capital. It's a very thin, like as I said, usually an API development or a batch timing. We're talking, when I don't want to scare anybody with the word implementation with you using that word, Doug, because it's a very different thing than you say standing up a full module. This is accessing a resource. Accessing a built resource is a better way to talk about it.
Exactly.
Yeah. Thanks, Rob. What's up? What else?
Sure. So I just wanted to pull back out. You talked a little bit about MPI. We have a question here. How does this solution change the need for an MPI? What are your thoughts on that when you look at identity as a module?
I'll take a stab at it, and then I'll open it up to the group. MPI really weaves itself across all of the themes that we're dealing with here. Maintaining we have to do a master person index when we have a new input come across. You send me Trey's identity information. Like, well, what is this? I need to match it up with my 30 years of history that I have on him. So MPI is sort of baked into the whole thing. As Doug said a minute ago, an overall master person index initiative at a state can be the genesis of what we're talking about here, like understanding the individuals across various systems that you can layer in the data augmentation over the top of. That might be the best methodology to get to what we're talking about here with the Medicaid identity module. But yeah, I think they're fairly inseparable. If you're asking about two different things, what are we talking about here and what is MPI? I think they're quite inseparable. The MPI is really just the kind of the golden key to unlock all of this. Any others?
Yeah, I'd say again, MPI to me is at one level, MPI is another technology. It's a platform by which you are managing this unique identifier, this unique look at an individual. But in order to make sure that identifier is consistent and can be applied very well across all of your modules, it's important what you're putting into that MPI, where the data about the individual information fueling that MPI is what I think is critical. And, again, like Trey said, it can certainly be the genesis of that centralized way of ensuring that all of the same golden record on an individual is applied to all the modules. That MPI can be the platform by which you do that. So they do go hand in hand.
Got it. So with the remaining time, just got a couple of minutes remaining. I just want to look at a little bit of application related questions here. One is an unwinding question. Are there states that are utilizing this approach to plan for unwinding to help sort of streamline workflows? If that's a yes, do you have any metrics on performance improvement associated with any of those projects?
So that's very much an in-flight type topic, right? We don't have the date yet. Sorry, we are approaching pilots, and when you say evaluate, that's a great way to look at it. We have launched an unwinding approach at Lexisnexis that I won't sort of belabor the point here, but critical to that initiative is we're helping states plan their actions, decide how they're going to tackle this topic. what we're finding is that they need an initial shakedown of what their file looks like, what their beneficiaries look like, and we can immediately change the workflow. Instead of I have 1 million people and I've got to go through all these unwinding steps on all of these people, and I got to run everybody down the rabbit holes and all those things. We're helping states take a different look at it in terms of, okay, you haven't touched them in 2 years plus. Let's take a look at that. Well, here, this portion of the population has expired. They've deceased. They're dead. So you don't have to worry. That moves to a different workflow. This population are duplicates within your file because of all the reasons, and you can handle those differently. These folks have moved out of state, handle that differently. You know, on down the line, we're performing some of those analysis for states right now to triage. It's an essential triage, the cleanup before you say I have to do 1 million things. Well, maybe the number is 800,000. You know, maybe the number is a more manageable number, and then you can get into workflows based on, okay, does Lexisnexis have a better address than you do for this person? Okay, we'll handle it that way. It really is a comprehensive data-based planning mechanism. So we took that one. I think we're getting close to time, but if anybody has anything else to add on to that one,
got it.
But I don't want to roll over, Rob.
Absolutely, yeah. And we're just one more sort of check the box question here, which I think will help people sort of decipher the on-ramping here as well. Are there data transfer tools? Are the data transfer tools FedRAMP or Mars E compliant? But I'm sure that's an important one that you guys would want to address.
Yes, and that's kind of you must be this tall to ride the ride sort of things, right? We've moved the bulk of our solutions to a cloud-based environment to accommodate all of that. We heard you, and we were listening.
Perfect. Look, I think that rounds us off here. I think that rounds us off. So thank you very much, everyone. We're just beyond time. Someone just put in the message here. They have an EMPI meeting go to as well. So there may be others joining that. But this is great. Thank you very much. Illuminating. Very much they're in context with a lot of the sessions we've covered this year. So really looking forward to learning more about Lexisnexis. I know you, the team writ large, will be at the annual State HIT Connect meeting, be running one of the roundtables there. And of course, you'll have the presence in the exhibit hall and so forth as well. So do join us. Email us if you need more information about how to get registered for that. But other than that, thank you very much to today's presenters, and we'll let you get on with your Tuesday. Thank you very much, and happy holidays.